Welcome back to Deep Dive Ortho, where we explore the compelling topics in musculoskeletal health. Today, we're diving into an articulation that's often underestimated, but actually profoundly critical, the sternoclavicular joint. Now, it might seem like a small piece of the puzzle, but its integrity is absolutely essential for the entire upper limb. To help us navigate this fascinating area, we're joined by Prof. Mo Imam.
Thank you for having me. It's a pleasure to be here to discuss the nuances of this joint.
Indeed. It strikes me that it's the only true skeletal connection between the axial skeleton and the upper limb, which, when you really think about it, makes its function utterly indispensable.
Absolutely fundamental.
So we're going to unpack its intricate anatomy, understand its vital role, delve into common pathologies, and explore the latest in diagnosis and management. Our mission today is to equip you with a comprehensive understanding, allowing for an even more informed clinical approach. Okay, let's unpack this. Perhaps you could set the scene for us. Describe the basic structure and functional significance of the sternoclavicular joint.
Certainly. The sternoclavicular, or SC joint, it's a saddle-shaped synovial joint. Its articulating surfaces are the clavicle, the manubrium of the sternum, and, importantly, the superior surface of the first costal cartilage. Crucially, unlike many other synovial joints, its surfaces are lined with fibrocartilage, not hyaline cartilage.
Right, that's quite distinct.
It is. And as you said, it's the sole bony link between the upper limb and the axial skeleton. Without it, a fracture of the clavicle alone can render the entire upper limb, well, virtually useless.
That really highlights its importance. So what are the key elements providing its stability? It must be quite robust.
It is remarkably stable. Stability is primarily derived from its very strong ligamentous structures. The posterior sternoclavicular ligament is paramount for anteroposterior stability,
Really?
whilst the anterior sternoclavicular ligament primarily restricts, or superior displacement. Then you have the interclavicular ligament, providing medial traction for both clavicles, linking them. And the costoclavicular ligament, anchoring the clavicle to the first rib, serves as the main restraint for the joint. It effectively resists elevation of the pectoral girdle.
The real workhorse, perhaps.
You could say that, yes. There's also a fibrocartilaginous articular disc within the joint. It acts as an important shock absorber and permits rotational motion, too.
It's a complex interplay. Are there muscles that directly influence the SC joint, ones that act on it?
That's a good question. Actually, no muscles directly act on the SC joint itself. However, its movement is heavily influenced by the motion of the scapula and the entire shoulder girdle. So muscles inserting on the clavicle, like the deltoid, pec major, trapezius, sternocleidomastoid, they all indirectly affect its function. And the subclavius muscle, arising from the first rib, also contributes to stability by depressing and anchoring the clavicle. And it's protective of the brachial plexus and the arm's vascular supply, which is vital.
And what about its neurovascular supply and anatomical neighbors? This is where it gets really interesting, particularly for clinical considerations, doesn't it?
Precisely. This is critical knowledge. The joint's vascular supply comes from branches of the subclavian artery, the internal thoracic, and the suprascapular arteries. Innervation is from the medial supraclavicular nerve, C3-C4, and the nerve to the subclavius, C5-C6. From a clinical standpoint, its anatomical neighbors are profoundly significant. You have the brachiocephalic trunk, internal jugular vein, common carotid artery, vagus and phrenic nerves, trachea, and esophagus, all lying just posterior to the SC joint.
Right behind it.
Exactly. Their proximity is a major concern in posterior dislocations.
So what does all this mean for its range of motion? How much movement do we actually get?
Functionally, it's a diarthrodial multiaxial joint. It allows movement in multiple planes. It offers around 35 degrees of motion in the horizontal and coronal planes, about 70 degrees anteroposteriorly, and 45 degrees of rotation along its long axis. It's quite a large range, influenced by the shoulder girdle, facilitating that fluid movement of the upper limb. Now, moving on to developmental points, which are vital, especially with younger patients, the clavicle's embryological development is quite unique. It's the first bone to start ossification between the 5th and 6th weeks of gestation. But its medial epiphysis is the last growth plate in the body to close, typically around 20 to 25 years old.
The very last.
Wow,
Yeah.
indeed. And this means injuries at this site in younger individuals, say under 25, are often medial clavicular physial fractures rather than true SC joint dislocations.
So it mimics a dislocation, but it's actually a growth plate injury. That's a crucial differential diagnosis.
Absolutely crucial. Misdiagnosis can lead to growth disturbance.
Are there any common anatomical variants that might present clinically, things we should be aware of?
Not many common ones, thankfully. Some patients might just have more prominent ligament attachments,
Hmm.
particularly the costoclavicular ligament. That's just physiological variation, nothing pathological. There's a rare muscle variant reported, the musculus interclavicularis inticus digastricus. It originates from the manubrium, inserts onto both clavicles, innervated by the lateral pectoral nerve.
And why is that relevant?
Well, it's vulnerable during procedures like subclavian vein catheter insertion or with clavicle fractures. Something to keep in the back of your mind, perhaps.
Right. Okay, given how robust it seems, what are the most common pathologies we actually encounter affecting the SE joint?
Well, despite its strength, injuries do happen. SE joint injuries are relatively uncommon, though, only about 3% to 5% of all shoulder girdle injuries. It takes significant force, usually high-energy trauma, thinking motor vehicle accidents, contact sports, falls.
Let's break down those traumatic injuries then, particularly dislocations. How are they classified?
Traumatic injuries are generally classified into three types, or grades. Type 1 or grade 1 is a simple sprain. Ligaments are intact, no laxity. Type 2 or grade 2 involves tearing of the sternoclavicular ligaments, but the costoclavicular ligaments remain intact. This leads to subluxation.
So partial instability.
Exactly. And a type
Yeah.
3 or grade 3 signifies a complete rupture of all ligaments. That results in a full dislocation.
And the direction of that dislocation makes a huge difference, doesn't it?
Absolutely. A critical difference. Anterior dislocations, where the clavicles push forward, are more common. They often result from an anterolateral blow to the shoulder. While they can leave a cosmetic bump, they usually have minimal long-term functional impact and are often managed non-operatively.
Okay, less worrying then.
Relatively speaking, yes. Posterior dislocations, however, are far more serious, much rarer, but much more dangerous. They tend to occur from a posterolateral force or a direct blow to the medial clavicle. Given those vital structures just behind the joint, the trachea, esophagus, great vessels, these dislocations carry a high risk of morbidity, even mortality.
That's sobering. What kind of complications are we talking about?
Things like pneumothorax, brachial plexus injury, vascular compromise, presenting with symptoms like difficulty swallowing, dysphagia, noisy breathing, stridor, or diminished pulses. A true emergency.
We've also heard of a snapping SC joint. What does that signify? Is that traumatic?
The snapping SC joint is quite a rare presentation, often seen in younger patients, adolescents particularly. It typically involves a sort of popping or subluxation of the medial clavicle, often triggered by specific repetitive movements, like external rotation with the arm abducted.
Yeah.
But importantly, it's generally a benign thing, not usually associated with significant ligamentous laxity, and it rarely needs intervention.
More annoying than dangerous, perhaps.
Often, yes, reassurance is key.
Beyond trauma, what about other conditions? Degenerative or inflammatory?
Osteoarthritis is actually quite common. Affects up to nearly 90% of patients over 50, radiographically at least. It's the typical wear and tear, causing pain with arm movements like flexion or abduction. You see joint space narrowing, osteophytes, subchondral cysts on imaging. Infection, though rare, is serious. It presents quite insidiously low-grade fever, redness, swelling, often caused by Staphylococcus aureus or Pseudomonas. Needs a high index of suspicion.
And systemic conditions like rheumatological disorders. Does the SE joint get involved there?
Yes, definitely. The SE joint can be involved in various inflammatory conditions. Rheumatoid arthritis, particularly in females, frequently affects it. Seronegative spondyloarthropathies too, psoriatic arthritis, ankylosing spondylitis, reactive arthritis, especially in HLA-B27 positive patients.
So quite commonly involved in those.
Yes, the incidence can be up to 90% in severe psoriatic arthritis, for example. Even gout, though uncommon here, can occur. You'd look for those negatively birefringent crystals on aspiration.
We also hear about conditions like SAPHO syndrome and condensing osteitis. Could you shed some light on those? They sound less common.
They are less common, but important to recognize. SAPHO syndrome, synovitis, acne, pustulosis, hyperostosis, osteitis most commonly affects the SC joint. It presents with inflammatory hyperostosis on CT and a characteristic bull's horn sign on bone scans. Condensing osteitis is a rare, painful condition. You see sclerosis of the inferomedial clavicle, but it's distinct from bone damage or infection. And then there's Friedreich disease, not the neurological one, but a vascular necrosis of the medial clavicle, more common in adolescents.
How do you differentiate that from condensing osteitis?
By symptom duration and definitively histological findings of bone necrosis and Friedreich disease. Both condensing osteitis and Friedreich are typically treated conservatively with NSAIDs initially.
Okay, so when a patient presents with potential SC joint issues, what's the typical diagnostic pathway? How do you approach it?
Well, it starts, as always, with a detailed medical history and a thorough physical examination. Patients often complain of anterior chest and shoulder pain, which might be well localized to the joint. You need to ask about trauma, obviously, but also insidious onset. Do they report recurrent subluxation, maybe a clicking or popping with certain movements?
And on physical examination, what are you specifically looking for? What are the key signs?
On examination, you're looking for any visible prominence of the sternum or clavicle, swelling, tenderness on palpation, maybe bruising if it's trauma-related. Assess the shoulder range of motion, which might be reduced, and then assess anteroposterior stability. Gently grasp the mid-clavicle, apply translational force, and always compare it to the other side.
Crucial comparison.
Absolutely. And crucially, for any suspicion of a posterior dislocation, you must perform a thorough assessment for those mediastinal injury symptoms, breathing difficulties, stridor, swallowing problems, checking pulses. That's paramount.
And in terms of imaging, what's the go-to modality?
Well, you might start with plain X-rays, maybe an AP, and a serendipity view. That's the 40-degree cephalic tilt.
Right, the serendipity view.
Yes, it can sometimes show displacement. The affected clavicle might be above the contralateral one in anterior dislocations or below in posterior. But standard views often lack sensitivity because of all the superimposed structures. So really, a CT scan is the imaging study of choice.
Why CT specifically?
It gives you excellent multiplanar evaluation, 3D reconstruction capability, and it's essential for visualizing those vital mediastinal structures in posterior dislocations. Plus, it's critical for differentiating true dislocations from those medial clavicle physeal fractures in younger patients we talked about.
Makes sense.
MRI can be useful too, perhaps for evaluating ligament or articular disc injuries in more detail. And angiography if you suspect a vascular injury.
Okay, let's move to management. How do we treat these conditions? Starting with non-surgical approaches.
Right. For atraumatic subluxations, and interestingly for chronic anterior dislocations that aren't causing major symptoms, non-operative management is generally the way to go. This typically involves reassurance, analgesia, maybe a sling for comfort, usually 1-2 weeks for sprains, maybe a bit longer for subluxations. Activity modification is key, avoiding heavy lifting or repetitive motions that aggravate it. And then a structured physical therapy program is really important. NSAIDs can help. And for inflammatory conditions, corticosteroid injections directly into the joint can provide temporary relief.
When does surgery enter the picture? What are the main indications and techniques?
Surgical intervention is definitely indicated for acute posterior dislocations, particularly if there are any signs of mediastinal injury, or if closed reduction fails or is unstable. Chronic or recurrent symptomatic dislocations, whether they're anterior or posterior, might also warrant consideration for surgery if conservative measures fail.
And for acute dislocations, what's the first step usually?
For acute dislocations, we often attempt closed reduction first, usually under general anesthesia. This involves techniques like axial traction and direct pressure, sometimes using a bolster under the scapula to help lever the clavicle back into place. But if this reduction is unstable, or if it fails, or particularly for complex posterior dislocations, then open reduction and internal fixation are necessary.
Could you elaborate a bit on those open reduction techniques? What's involved there?
Sure. Open reduction typically involves a curvilinear incision over the joint to expose it. The goal is reconstruction, often using a figure-of-8 tendon reconstruction technique. This frequently uses an allograft, or perhaps an autograft, like gracilis or semitendinosus, which is woven through drill holes in the clavicle and sternum to provide robust stability.
Like creating a new ligament, essentially.
Exactly. Medial clavicle excision is an older procedure, less common now. It's typically reserved for severe osteoarthritis refractory to other treatments. It involves resecting a small amount, less than 15 millimeters, of the medial clavicle, being very careful to preserve the costoclavicular ligaments. And for infections, it's quite different surgical debridement, and often an en bloc resection are needed, along with appropriate antibiotic therapy.
And after these interventions, what does recovery and rehabilitation look like?
Post-reduction or surgery, the arm is usually immobilized in a sling or sometimes a figure-of-8 strap for about 6 weeks. During this time, there are strict activity restrictions, absolutely no heavy lifting for several months. Rehabilitation protocols generally span 4 to 6 months and follow a phased approach. You start with gentle passive range of motion in the early phase, say weeks 0-6, then progress to active assisted movements and light isometric strengthening in the intermediate phase, weeks 6-12. And finally, a comprehensive strengthening program in the late phase, beyond 12 weeks, to restore full function and dynamic stability.
A structured progression seems key.
It really is essential for optimal recovery.
So looking at the bigger picture, what's the overall prognosis for SE joint injuries, and what complications should clinicians really be vigilant about?
Generally, the prognosis is quite favorable. Great eye sprains often resolve fully within a week or two. Anterior dislocations typically do well functionally, although that cosmetic deformity, the bump, may persist.
Patients often notice that.
They do. Posterior dislocations, however, carry a guarded prognosis. That's due to the high risk up to 30% of complications involving those adjacent vital structures. We're talking tracheal, esophageal, brachial plexus, or great vessel injuries. Sadly, fatalities have been reported, and even if there are no immediate signs, an unreduced posterior dislocation can lead to significant late complications.
What are the most common long-term issues patients might face after SE joint problems?
The most common complications tend to be persistent pain and that cosmetic deformity we mentioned. Patients are also at an increased risk of developing sternoclavicular arthritis later on, and the risk tends to increase with the severity of the initial injury. Surgical complications, though less frequent, can occur. Things like hardware migration if fixation was used, infection, recurrence of the dislocation, and sometimes less than ideal cosmetic results. It really underscores the importance of careful patient selection for surgery, precise technique, and diligent rehab.
That was a truly insightful deep dive. Your expertise has really illuminated the complexities and the clinical significance of this, well, often understated joint. From anatomy to management, we've covered a lot.
My pleasure. I think understanding the SEC joint's anatomy and biomechanics is absolutely fundamental, especially appreciating those distinct risks with posterior dislocations and remembering that crucial difference with physeal fractures in younger patients. Getting that right is paramount.
Absolutely. It seems the prognosis is generally good, but that careful, tailored approach is essential for the best outcomes, especially in complex cases. And if you, our listeners, have found this deep dive valuable, please do consider rating and sharing our show with your colleagues. Now, for our medical professionals listening, here's a final thought to ponder. How might a seemingly minor issue with the SC joint, perhaps just a cosmetic concern or mild ache, subtly impact a patient's overall quality of life, their confidence, their activities, maybe even their psychological well-being, far beyond just the physical symptoms? It's a reminder of the holistic view we must always strive for in orthopedics. Thank you for joining us on Deep Dive Ortho, and we look forward to our next exploration together.